Dr. Juergen Liebermann. I did my master and my PhD in animal science in Germany at Technical University of Munich. I did my lectureship and professorship at the University of Würzburg in 2004. And I started IVF actually in 1996. And in 2004, I left Germany for a position I took here in Chicago at the Fertility Center of Illinois. And I'm still the lab director of this IVF center since then. The procedure is still time-consuming and requires special attention by the embryologists. And so because of the increasing number of cases, when you follow the SART register and even when you go to Escher, like last year, Copenhagen, there was reported a tendency in increasing of freezing cycles, thawing cycles, regardless all sites are embryos. For many years, when I gave lectures on freezing of embryos, about 20% of all cases of embryo transfers were like using thawed, frozen oocytes or embryos. This number now is already beyond 30%, and I think 2030 we might talk about 40 to 50% of all IVF cases and babies born from frozen eggs or oocytes. So this development required to look into the protocols we work now for 20 years is a need maybe to reconsider them, to readjust them. The dogma of cryobiology is if you freeze oocytes and when you warm them, you have to do that in steps. You have to dehydrate in steps, but also more important, rehydrate in steps to remove the cryoprotectant by going through different concentrations of sucrose, for example. And so if we would find a protocol that would just not require these sequential steps of exposure to cryoprotectant or doing warming at different sucrose concentration by using only one step, that would be by getting 100% survival or even over 90%. That would be an enormous success in terms of definitely better quality, less effective, or in terms of ROS building for the embryos, less exposure at room temperature, and we would have a lot of time we would save and costs. Before every embryo or zygote or embryo and oocytes were frozen at a slow traditional freezing. That was a protocol that took, depending on what stage you froze, 90 minutes to 2.5 hours. And for this, machines were used to cryopreserve oocytes and embryos. And it went in different ramps until about minus 35 to minus 40 degrees, and when it was plunged. And the temperature per minute was about 0.3 degrees Celsius. So that's why it took this time, as I mentioned before. And when also the machines we used were also limited if the number of embryos we were able to load. And so, over time, especially from the animal section, in the mid-90s, there were some people that thought about, how is a way to freeze embryos different than oocytes. Initial work, groundbreaking work was done much earlier, like in the 40s, by a monk from Switzerland who moved to Wisconsin, Michigan, and published his first manuscript on vitrification. And vitrification, the idea was here to cryopreserve oocytes and embryos in a way that we prevent ice crystals, because ice crystals inside intracellular would be lethal for every living cell. So how to achieve this? It had to be very fast. It had to be very fast in terms of time, and it had to be a much higher concentration of cryoprotectant to prevent the building of ice crystals. And so vitrification was born in the animals in the mid-90s, and then, actually it switched over to humans. The first successful vitrification of oocytes and live birth was reported in 1999. First of all, we worked on the vitrification. We cut down the time of 9 minutes now to 5 minutes. So we usually expose the embryos 4 minutes to the first solution. It's called an equilibration solution. It's 7.5% of 2 different cryoprotectant. And then it follows like 1 minute exposure time to the same cryoprotectant, but now in a concentration twice higher. So 15% of both. That would be a total concentration of 30%. That takes 5 minutes. But the major saving in time is the warming. And it took us before about 11 minutes because we had to follow these protocols, as I mentioned before, these sequences of sucrose steps to dilute the sucrose and remove the cryoprotectant. And that took us 11 minutes. But now we do it in 1 minute. And we achieved the same outcome, even better, more consistent. And it's successful. And it's also providing you many other things, a very efficient workflow in a big IVF center. as I mentioned before, we have more and more cases where we do biopsy that requires freezing. So we will have more transfers of frozen embryos and thawed embryos. So having now a protocol where you thaw 1 minute embryo instead of 11, that is a huge time saver, especially when we talk about 10 to 15 FETs a day, where we needed 2 embryologists to thaw them. That is all now done by 1 embryologist. Yeah, you know, when we are long enough in that field, we might would remember that certain things were done very long before us in the bovine industry. And you know, bovine industry has to think about protocols that are very sophisticated, but also simple, because you know, you transfer embryos under field conditions. And under field conditions, so it's not necessarily an incubator, it's not necessarily a working bench or a microscope. So you have to thaw embryos right off the nitrogen chain and transfer them in the uterus of the cow. So you know, that was for human just not possible, not thinkable. But you know, that was a beginning where we still have people, they remember this, they worked in that field. In particular, for our case in human IVF, it was an accident. And when it was published and we got a prize paper at the PCRS and ASRM, and that was a working group around Teal Tyler. So, you know, in many things like this, you need someone who made a mistake, and you know, we have to move on. So, you know, somebody like me, I picked it up and went home and did my validation of this protocol for blastocysts. And I thought about 600 blastocysts we had in-house donated for research by patients signing that disposition. And so we saw, no, quite fast this works, and it's amazing. But N number is power, so I went to 600, and then we made, after 5 months of validating this protocol, we made a decision to establish this in a clinic setting, and we switched in September 2022, and since then we employ that protocol. So, yes, a clinical outcome we now can report. So first of all, it's a positive beta. A positive beta for a patient is usually you know, measured after 10 days of transfer. It is generated by the embryo. It's an hormone, human gonadotropin, chorion gonadotropin, and this lets you know, there is an established growth of embryo tissue. You know, this is a very early beginning, and we have here these first betas usually, regardless of age, beyond 70%. Of course, you know, when you move on a couple of weeks later, you look for a sac, an embryonic sac, and then a fetal heartbeat. And when we have both now observed, we can actually call it an ongoing pregnancy. We have usually over between 55 to 60% ongoing pregnancy with an implantation of 60%. On top of this, I want to mention, you know, we already have reported live births. I record, of course, these transfers. You know, I have my Excel sheet because for the reason, you know, to see, is this technique safe, and does it provide healthy live births? And so far we can report more than 900 live births out of 1,400 transfers, and there is no increase in malformation or other defects observed than we saw before. When we talk about oocyte vitrification, we usually still employ a protocol that also requires 2 steps: an exposure to an equilibration solution, and we do that for 15 minutes. You know, some people do it 10 minutes, but definitely 10 to 15 minutes. And then the final step in the higher concentration in the vitrification solution is 1 minute. So we would freeze oocytes in 16 minutes. And this is usually considered per 2 oocytes, right? You can start with more oocytes, and then, you know, we have to step down, but you make sure oocytes are not too long exposed. But it takes time, and by freezing only 2 oocytes per carrier, it is also time consuming on top of the time we need to expose them to the cryoprotectant. So warming itself is still 11 minutes, I'm sorry, and it requires also time and certain steps to remove the cryoprotectant. So my protocol is different. It is only 2 minutes compared to 16 minutes. It's an exposure time of 1 minute to each solution, 1 minute to ES and 1 minute to VS. And the warming also is 2 minutes. And I moved away from the traditional first step using TS. This is usually the first solution we thaw embryos, and it is 1 molar sucrose. I moved on to a lower concentration of sucrose, 2.5. That's my first step for 1 minute, and then 1 minute in a water solution that has usually no sucrose. And so after 2 minutes, I'm done with farming oocytes, and the results I published. I did use immature oocytes where I have no use for patients, and you know, to finish a successful journey to parenthood for them. But they're a good study objective, so I froze them, cultured them overnight to see if they regain their meiotic activity. And yes, they did. And so we, even with 2-minute exposure time, freezing and warming, it does not destroy the cells. It keeps their potential to move on in terms of maturity. Also fertilization shown by others, and embryonic development compared to the protocol that took much longer. Of course, when I talk saving of time, this is um, a beautiful side product of the protocol. Validation and safety and patient care, it's the most important thing, right? But if you achieve the same result by cutting down the time from 11 to 1 minute without compromising the integrity of the embryo and the chance of the patient to get pregnant. So, there is no time to wait for and to move on. We need long-term studies. This is like with everything, right? This is when we talk about the oversight protocol later, there is no question that I have to remind people this is the beginning of a new area of different vitrification protocols. So we need make sure, and people did already, metabolomics and other studies to make sure, that we now saving not just time, that these embryos and oocytes get not compromised in very many ways. It is mitochondria, is it endoplasmatic reticulum, is it the meiotic spindle? There's a lot of things we have to look for, and this is done in a proper way to make sure, when we implement these protocols, they're also safe for embryos and for the patient. So I played with media because it is important, again, for a person who is a practitioner. And the reason is quite simple. We see more and more embryos coming to our center. We didn't freeze. And so we have to be prepared for this because, we have in-house a decision made for what is our freezing media, what is our warming media. But when we get embryos from somewhere else, they are not necessarily frozen or in the same medium we employ it in-house. So of course I did try different concentrations, different media. I crossed them with warming and freezing. And on the end of my story is actually this media all interchangeable. And this is very important for practitioners. When we get embryos where we're frozen on a different media we usually have in-house, we will thaw with the media we have in-house, and these embryos and oocytes do fine. Also, the milestone is, to encourage more people to try more out. Usually experience a huge interest, when I, as you mentioned before, on LinkedIn and publish my results I found, to share them. This is usually to encourage people. And we have excellent scientists. I just returned from Brazil. I was happy to be invited there as a speaker on different topics. And we have a generation of young embryologists. They are hungry for knowledge and desire to try new things. So I like to encourage people to develop and keep going scientific thinking, and to move on with these protocols in a broader spectrum worldwide, and see how how we will implement that. My prediction is that we will, in end of this century, in 2030, we will freeze embryos different. We will freeze them, as I reported before, in a very short time, and we also will freeze and thaw embryos, oocytes, in a much shorter time as we usually do now.